Okay, we might get started. Welcome to this week's NDARC weekly webinar. My name is Sarah Feinbach. I am your host this afternoon. I'm also a researcher here at NDARC. And today I have the great pleasure of introducing a webinar by Dr. David Goodman-Meza, who is a senior research associate at Kirby Institute and has been since 2024. David is a clinical scientist with expertise in infectious disease and substance use disorders. He also works as a staff specialist at St Vincent's Drug and Alcohol Service and at Parklea Correctional Centre. He's a busy person. Today, David will be talking on identifying people who inject drugs using electronic health records. It's going to be a really interesting talk with lots of fancy tech, which I'm looking forward to. For the panel, David has asked for Dr. Amanda Roxburgh to join us. Now, many of you will know Amanda. She's a research fellow, senior research fellow, and a clinical psychologist. She has over 20 years experience in drug and alcohol sector and is a national and emerging international profile relating to her expertise in opioid overdose mortality, and also a long-standing friend of NDARC. So after David has finished talking, we will be taking questions as we usually do. So if you have any questions or wonderings, please pop them into the Q&A function. We'll try to get through as many of them as we can with our presenter and also with our panelist. So that has got me through my background. But before we begin, I did just want to start by paying my respects to the traditional custodians of the lands where we're meeting from today. In my case, it's from the Ngunnawal and Ngambri lands. And I would like to pay my respects to elders past, present, and extend that same respect to any First Nations people who are joining us here today. Okay, I'm going to get out of the way and ask David to please turn on his camera. Looks good. Thanks, David. And over to you.
Well, thank you very much, Sarah, for that eloquent introduction. As you mentioned, my name is David Goodman-Meza. And I'm really excited to be here. I really first want to thank you all at NDARC for this invitation to be able to spread this work. And then everybody who has joined on a busy Thursday afternoon, thank you for spending this hour with me. Hopefully I'll try to make it as enjoyable as possible and not as arid when we go into looking at a bit of the data. But please, if you have any questions, please have them handy. I've also included my email here on this slide, the last slide, and I think on my little box around my name. So please email me if you do have any other questions, ideas for collaboration, and whatnot. I do have to disclose that a lot of this work was funded by the US NIH and especially the National Institute on Drug Abuse. Just a little bit of context about me. As Sarah mentioned, I'm a clinical specialist in substance use disorders, in addiction medicine and infectious diseases. And really my research interests lie where these two circles in the Venn diagram meet, really trying to understand how one leads to another or how improving one will improve the other, and how do we develop different interventions to improve these health outcomes. And a lot of this work came about early when I was a clinical infectious diseases fellow at UCLA. And at that point, I had proposed somewhat of a fellow project where I was going to look into the electronic health record there at UCLA to look at outcomes, I think, for people who inject drugs, who were being admitted to the hospital with endocarditis. And so I went through the whole process with the tech agency within UCLA to get the data from the electronic health record. And ultimately, I had to give a bunch of ICD codes, got a bunch of data, started analyzing it. And when I went to verify the data within the actual charts, it made no sense. A lot of patients that had all of these codes for opiate use disorder, methamphetamine use disorder, cocaine use disorder, didn't actually have these substance use underlying disorders. A lot of cases that had codes for endocarditis didn't really have endocarditis. And so this spurred for me a lot of questions around how can we identify this population much better within this kind of valuable resource, which are these electronic health records, right? And so that's a little bit of the how I got here to this particular field of research. After I proposed an NIH K award, which is somewhat like a career development award, that really allowed me to devote 75–80% of my time as a junior faculty member at UCLA to really train up in these methods around machine learning and natural language processing that I'll talk a little bit about later. So just as kind of broad objectives of what I would love you to get out of this is really to understand the importance and methods that we use in research to identifying people who inject drugs in electronic health records. I tried in this slide, I try to keep all the keywords that I'm going to be abbreviating all in this one. So people who inject drugs, PWID, electronic health records, EHR, and then natural language processing as NLP. So you might see that repeatedly during the presentation. Hopefully I don't have many others. Then really define what natural language processing is and describe its evolution. I think this is quite prescient right now with given all the hoopla around AI that surround us, and all of, I imagine most of us have used some service such as ChatGPT, Claude, or many of the other ones that are out there. But this might help a lot of people who are not so familiar with this area of how we got to these quite amazing chatbots. And then I'll present data from my work related to the diagnostic accuracy around many of these models as tools to identify people who inject drugs. And I mean, hopefully self-serving to myself is really, one goal for myself would be really to interest people and hopefully build collaborations for future work. So why does identifying people who inject drugs in EHR matter? And it's quite obvious for probably most of us who are here. We're probably speaking to the choir, but we know that this is a group of individuals that are really at risk for several poor health outcomes, which might include overdose, acquisition of HIV and hepatitis C, or hospitalization, or just acquiring different bacterial infections, such as skin and soft tissue infections, endocarditis, or infections of the bones and joints, amongst others, right? And electronic health records, really, in the last 20 years, we've had this massive shift in the healthcare industry where most, I would say 99% of medical centers have shifted from documenting their patients' records from paper charts into now electronic health records, right? And with electronic health records, we could really understand from an epidemiologic purpose, well, what are the proportion of people who are people who inject drugs that are engaging with our different health services. This in turn could allow for better resource allocation, say funding to provide wraparound services for people who inject drugs. How do we better locate distinct testing and treatment services, such as those for HIV and hepatitis C, as well as where do we implement different harm reduction strategies like treatment for opiate use disorder with buprenorphine, methadone, or syringe and services programs. We could also better develop interventions and better evaluate health outcomes in this group. And I think this comes up a lot, this kind of idea of clinical decision support. So this idea that the doctor or the nurse or whoever is writing about this person and is document that this is a person who's injecting drugs, and then there could be some kind of advice to the provider, start this patient on buprenorphine or screen this patient for hepatitis B or hepatitis C, right? And although this might be the kind of Star Trek, Star Wars future of medicine, I still think we're several steps and several technological movements from that piece. But we can talk about that a little bit more in the discussion. So currently, we have many different sources where we identify or where we get data around the numbers of people who inject drugs, who access healthcare services, or who live within our communities, right? We can find it through general population surveys, surveys of sentinel populations, through population consumption data, administrative data, and then lastly, the kind of focus that I'm more interested in is really through electronic health records. And I show this through the slide that just to show that electronic health records is just one small piece of how we could be better doing this kind of case finding work to, again, improve services for these folks that we want to improve their health outcomes in. So just a definition for electronic health records. These are digital versions of a patient's medical chart, contains comprehensive health information that is created, managed, and stored by healthcare providers over time. I guess I forgot an enter there for a bullet, but it would include demographics, progress notes, so the things that doctors, nurses, allied health, pharmacists, social workers might be writing about the patient or the patient's care. And this is really where my work is focused. But again, there's much more data that we could be using probably to better improve this task. So EHRs also contain diagnoses and problem lists encoded as, for say, ICD-10 codes or SNOMED codes. They contain medications and prescriptions from the pharmacy data, vital signs, lab data, radiology reports, immunization history, past medical procedures, many others. And I think one that's not on the slide is ever more often we have digital health trackers, say your Apple Watch or your Samsung Watch, that might be collecting some sort of health data, be that your ongoing heart rate, be that your weight, height over time that you might be entering into it. And these can be then integrated into the electronic health record. So these could be, again, more data points to use. So I'll be talking broadly of different data pieces within the EHR that we might be using to identify people who use drugs, right? And one would be survey data. And survey data, right, is really this incredibly rich data source that really comes from these detailed behavioral questionnaires. There's many validated instruments out there. One that we used a lot in studies in the US was this like NIDA assist, the DAST. So there's many audit specifically for alcohol. So there's many different validated instruments out there. However, most of these surveys are really mostly restricted into the research context, and rarely are they really integrated into clinical practice well. However, we see this happening more and more often, right? And so we'll give a patient an iPad while they're in the waiting room to collect some of this data, or some of this data might be collected maybe through like a triage nurse. And so this can then be integrated into our EHRs. Other times we had a feature where through Epic, we could send questionnaires to patients through their apps or through their patient portals, and then they would see something like you're seeing here on the screen that they would be able to click on, and another point for collecting data. And of course, this data is not perfect. It's of course susceptible to recall and social desirability biases, right? Especially when we're talking about smoking, alcohol, drug use. Do I really want to let the big brother machine know about these behaviors? And especially if it's not necessarily directly involved in my patient care. So I could definitely see many patients not answering these or not answering these truthfully. The other data point that is used very commonly in a lot of the research we do, right, are these ICD codes. And ICD codes are these International Classification of Diseases codes. They're put out by the UN, and then they're adapted by different countries and slowly adopted by the different health services within that country. Currently in Australia and in the United States, we're using ICD-10, ICD-11 is out, and we'll probably transition at some point, although I'm not sure when that would happen. ICD-10 codes are really useful in the way that it enables comparisons across health jurisdictions. Although the caveats for our specific interest is that there's no specific code for injection drug use, right? So there's different codes for related things, like if you have a substance use disorder, like opiate use disorder, alcohol use disorder, the cocaine use, stimulant use disorder. There's other codes for events like intoxication related to one of these substances, or poisonings related to these substances. And so many researchers have used different combinations of these codes as proxy algorithms to try to identify people who inject drugs in these electronic health records. One of the big pieces here is that these codes are entered into the EHR either by physicians as part of their billing and coding practices. So in many places, you see a patient and then you're required to put in one of these codes, and depending on the number of codes is the amount, the service level that you're able to bill. And in many other places, these codes are entered by professional coders, where the doctor writes a note, and based on that note, the coder reads through it and then enters the codes into the system that are then used for billing purposes. Because of that, of course, there are many biases and many points along the way for those codes to actually enter the EHR that could lead to much error. And this is something that I'll talk a lot about later. Another way of identifying people who inject drugs in the electronic health record is really through manual review. And this in many ways considered the kind of gold standard. So we have an actual human, typically medical students or research assistants, go through the mass of a patient's chart and look through all of the different documentation, look through different lab reports, and then make, based on some kind of case definition, a judgment of, is this a person who injects drugs or not? As you can imagine, this is quite labor intensive. It's really not scalable when you have 100, 200, a million records. And it's quite hard to reproduce from one center to another. The other piece, there's some issues with inter-rater variability. And because of the cost and the time, the insights you might gain from these manual reviews are really delayed, right? By the time the person does this massive review, you get through all the ethics pieces, you hire the people, you actually do the review, and you publish your findings, it's years down the line. And then again, this is susceptible to, again, the recall social desirability and reporting biases, as many of the other methods also are susceptible to. We could also try to identify people through urine toxicology, and so this is really an objective biomarker, really substance specific, although for some substances not as specific, right? Because an opioid screen might catch codeine, heroin, or morphine, and you might not necessarily know exactly which one, which substance this person is using, especially with some of the point of care toxicology testing. Although with more kind of advanced confirmatory testing, you could know which are the precise substances, but this isn't really used routinely. One of the caveats with this method is that you really wouldn't be able to identify the route of use, right? You just know if substance is present in urine, but you don't know if they've been using it orally, if they've been injecting it, if they've been smoking it. Although it is routine in many settings, depending on the types of encounters. So you have somebody who comes in for an acute intoxication to the emergency room, you might order this pretty routinely, but for many patients maybe seen in primary care or seen in outpatient addiction settings, this might not be something that you're ordering at every visit. And so ordering practices are going to vary. The other piece is that the detection window for many substances are really short, right? So for most substances, really except cannabis, the detection is really around 72 hours. And then it's really hard to distinguish, is the substance being used as prescribed or non-prescribed? Although you could tie it in maybe to somebody's pharmacy records, and for some other substances, obviously, there is no prescribed use, like say cocaine. So you could figure it out, but for many other pieces, you really would not be able to know. The other one, which I think is quite exciting to me, is really using machine learning. And I'm going to talk first about machine learning without natural language processing, and that'll be next. But so machine learning without NLP really utilizes readily available fields that are structured. So different fields throughout the electronic health record that structured, like, would include age, gender, the types of encounters that they're having, the different labs that were ordered during the visit, if these labs were positive or negative. And so once you set up a model that you've trained and tested, could be reproducible, scalable, and quite efficient at identifying people who inject drugs. It'll probably lose a lot of the nuance of details that are coded in the notes that you really, with this approach, you wouldn't be able to capture. And then one of the big problems with machine learning, which I think is getting less of a problem, is the lack of explainability. We've always thought of machine learning as this kind of big black box that we put data in and we get an output out, and we don't really know what's happening in the in-between. However, now, although you don't know these precise interactions of every input, you can figure out which are some of the inputs that are the most important to explain what the outputs are. And then I think one of the drawbacks, of course, is going to be you really need people who have a lot of expertise in data science to develop these and really to keep them going, because one of the variables names changes and the system might collapse on you. So it really does require ongoing refinement and ongoing development. And this, I guess, will segue us to our first slide that'll be presenting data. This was a paper, not mine, from colleagues down in Melbourne. I think this is a really great paper and really interesting, where they used data from really cohort data from a group called Access, and then looked through their electronic health records. So they had a label of people that they knew were people who injected drugs. They took a random sample of people that they somewhat presume were not people who injected drugs, and they had this data set where they could then test all the different variables within their electronic health record to see what were the accuracy of identifying somebody as a person who injects drugs or not, and then what were the different variables that were most predictive of this. And they scored for many of the diagnostic accuracy measures above 90%, which is quite excellent. And then they used what they found in this chart down here is, of course, measures as if a person was prescribed opioid agonist therapy, if they were tested for hepatitis C, and many others that were really highly associated with the future label of, is this a person who injects drugs or not? And then lastly, the other kind of way I think we could figure out if a case would be a person who injects drugs or not is using natural language processing, which I'll probably use the bulk of the time left to talk about. So just as a definition here, natural language processing is a subfield of computer science that focuses on enabling computers to understand, interpret, and generate human language in a way that is both meaningful and useful. There's many different tasks that NLP deals with, really, like the conversion of human speech to text and vice versa, for, say, when you interact with Siri, Alexa, Katana, any of these assistants on your phone, that's a result of NLP. There's a field called sentiment analysis, where you can kind of get a general rating of if a text is positive or negative in regards to sentiment, and then use this for further analyses. The piece that I'm really interested in is really this text document classification task, and we'll talk more about this. But there's other tasks like topic modeling, where you give it 100,000 notes, and then it figures what are the most salient topics that are being talked about in these notes or in this text. Content extraction, translation, and a lot of what we do with the new large language models like summarization, chatbots, and text generation are really quite impressive. So I'll just go briefly into the history of NLP. And really, since the advent of computers, we've been trying to input textual data and really learn insights from it, right? However, during the early 1950s till about the 1980s, the most common or really significant approaches were really all based on rules, right? And we do this all day. You hit Control F in your Word document, and you type in a word that you want to look for in a certain text, right? So of course, there's much more sophisticated rules patterns that you can make with these regex type of patterns, and so you could do much more sophisticated things just with rules alone. However, come the 1980s and 1990s, with kind of our advances in statistical approaches, our advances in development of AI and machine learning, and then the massive amounts of data that come with the textual data, especially coming with the World Wide Web, machine learning approaches become much more interesting. But it's not really until the 2010s where there's these really massive improvements in computer hardware, and especially the introduction of GPUs or graphical processing units that are really able to analyze this highly dimensional data rapidly, that we can really use deep learning approaches to analyze a lot of these text data and really build large language models through the use of deep learning. And so I'll talk a little bit about this. One of the biggest pieces that happened, and I'll talk next about this, is Google published this algorithm called Word2Vec. And from there, this field of NLP to me exploded extremely rapidly. I got in on this in 2018, and when I first started, I would see that NVIDIA was the only chip that you could actually do a lot of this work. And sadly enough, for my life, that I'd never connected the dots that I could invest in this company and maybe make a lot of money and not have to do this work. But I was too stupid at the time and never invested any money in it. And so I'm stuck doing this work. But so from Word2Vec, a lot of different models started being developed. And I think really around 2018, 19, with the introduction of what we call these BERT models that really advanced the field, and then developed into now these more generative models with the advent of the ChatGPTs, the Llamas, Claude, and whatnot. So it's really exciting how this field has advanced extremely fast in my short professional career. And then I'll just talk a little bit about machine learning, because a lot of the work we do within natural language processing really relies on machine learning. And so machine learning is really trying to learn insights from data using different computer algorithms. And so we can classify it. We see three here, but there's two big types of machine learning. One is supervised learning, that's here on red, and the other is unsupervised learning in blue. And then with supervised learning, we give the computer what we want to predict, and we give it all the available data that it has to predict that, and it figures out which are the most important data points and the combination of these data points to make that prediction. And so within supervised learning, we can have a classification. So in this case, the red would be, are these people who inject drugs? And in blue are the people who do not inject drugs. So it's a very classification, yes, no type of problem. But a lot of other tasks within machine learning are really regression problems where we're trying to predict some kind of number within a multitude of numbers, right? Briefly, unsupervised learning is the opposite of supervised learning, where we don't give the computer the labels that we think classify it, and we let them figure it out. So if we, I don't know, we give it 100 notes from different patients, and hopefully it would be able to separate out that salient features of these notes, or that these greens are people who inject drugs, these reds are people who don't inject drugs, and I don't know, these blues are maybe uncertainty or something like this. However, we don't know that that's going to come out, and it might figure out, you know what, to me, the most important topics are, well, these green ones are patients who got admitted because of a heart valve infection. The blue ones are because they got admitted for a brain infection, and the red ones got admitted for a bone infection. So we don't really control what the different topics that it's going to figure out are. So I promised I'd talk a little bit about word-to-vec, because I think it's so fundamental for the understanding of how the different large language models work. And it's really this concept of embeddings. And what embeddings are is that for mathematical models to work, we need words to be converted into numbers. And there's many rudimentary ways of doing this. You could make a big, massive grid with all the words as columns, and then when it appears, you do a 1 or a 0. But these techniques, like one-shot encoding, are really not efficient and don't produce really good results until really these things that we call embeddings come out. And word-to-vec, what they did is that for every word, they map these words into a very highly dimensional space. And so that words that are very close in meaning to each other share that highly dimensional space, so they're very close together, where words that are not close in meaning would be separated from each other. And the amount of dimensions vary. You can train models to be of 50 dimensions, 100 dimensions, 150 dimensions. The BERT type of models use 768 dimensions. So we really can't grasp this in our brains, right? We can think of 2, 3, maybe 4 dimensions. But the computer can figure this out, right? And so they've done examples where once they've created these highly dimensional spaces with the different words, they can show that words like queen and women are close enough on one plane, but then queen and king are close enough on a different plane, and then king and man are close enough on a different plane, whereas king and woman aren't as close because they're much less related. And so I did this with, in one of my early projects, with different words within the electronic health record, and looked at, once you flatten all these dimensions into a 2-dimensional space, what do they look like? And so we see in the top left corner the different words in purple that are similar to heroin, and we can see that words like methamphetamine, meth, IVDU, which is an acronym for intravenous drug user, cocaine, smokes, uses, popping, were all very clustered to heroin. Other words, we'll say in the lower right-hand corner, that are very similar to vancomycin, in green, like meropenem, ceftriax, should be an X here, ceftriaxone, or in the Australian ceftriaxone, zosyn, vancomycin, gentamicin, daptomycin. These are all different antibiotics that somewhat cluster together, and without us telling this language model, without us giving it any knowledge, it figured out that these words should be clustered in a similarly highly dimensional space. Word-to-vec was very rudimentary in that it was context independent, whereas newer models can actually cluster the same words in different areas dependent on the context around them. And this is really what gives them their ability to whatever, predict the missing word in a sentence or predict the next word and generate new text. So I'll talk a little bit about my work in the field. And one of my first works was really developing and algorithms to identify overdose deaths in coroners or medical examiners types of records. And that in many ways is much more of a simpler task because the coroner's reports, at least for the data that we had, were very short. They were anywhere from 8 words to 30 words, right? However, I think more interesting for this talk is really this paper here that it was really looking, and I'll talk a little bit more about it, was really looking at how do we identify people who inject drugs in the VA electronic health record. And then I'll show data from this project where we really show how important it is to identify people correctly when we're doing like comparative effectiveness analyses or epidemiologic analyses. And then I'll be presenting some of the newest work that we have from a group that I used to work with or I still work with at UCLA, now using the much more newer large language models, and then work that I'm currently doing at St. Vincent's Hospital. So the first work related here is around people who inject drugs, and I know I have to speed up, but this was around 36,000 cases with Staph aureus bacteremia. We took 1,000 notes. We had research assistants and myself go through them. We trained models, large machine learning models, to identify which were the most important words to identify who were people who inject drugs and who are not. And we compared these to the different combination of ICD codes that have been published previously in the literature. And we showed that the ICD codes were not much better than tossing a coin and these different combinations of different substance use disorders with HIV, hepatitis C. At least in the VA, we're not much better than a coin flip at really identifying people who inject drugs. Our algorithms with a keyword negation called negex did okay at 0.75 of an F score, but really using negex, which is a rules-based algorithm, we were able to achieve more than 0.9 F score, which is really good. Then we did some external validation in a data set called Mimic, and we actually saw that the models did better in the original data set, which was really encouraging and impressive. So we were really happy with this work. The next work is that within that same data set, we said, okay, well, using these algorithms, how many people would be identified as people who inject drugs using ICD codes in red? And how many people are actually ICD codes using NLP, which we think is a much more accurate estimate. And so we see that ICD codes overestimate, at least in the VA, close to 7 times higher the proportion of people who inject drugs compared to using NLP. And then we tested it on the question of, does starting people on methadone or buprenorphine, although 95% of the patients were started on methadone, does this improve outcomes within 1 year? And this is 1-year mortality. So when we define the cohort with NLP, we see that we have a 50% reduction in the hazard of death within 1 year. Whereas when we use an ICD-based cohort to identify these patients, we see no difference. And the big problem here that we did when we manually reviewed these cases was that a lot of the cases receiving methadone for within the ICD cohort were actually for palliative care. So it was really biasing the estimate towards the null because these are patients that are more likely to die within the next year. So just using, did the patient receive methadone or had an ICD code for this would really have severe impacts on what your estimates are of this really important intervention. So one of the criticisms would be, well, this is old data, these are old models, this is the United States, this doesn't apply to Australia. So I've been trying to do some work at St. Vincent's Hospital. I don't have Oh, so sorry. Before that, one of my students, Fabrice Harel, we currently have this under review. He used the new large language models from the different companies like Facebook called Llama, DeepSeek, GPT, so the one from OpenAI, and tested it on in a mimic data set on its ability to identify people who inject drugs. And then he created a model that is fine-tuned to do this task and was able to detect correctly with an F score of above 0.9. And then for most substances was able to do this at a rate of above 0.9. We still have a lot of trouble detecting prescription opioids, and in the discussion we can talk a little bit more about this, which has been a consistent challenge for us. And then, sorry, the work that I've been doing here at St. Vincent's, I took a cross-sectional cut of data between 2018 and 2020 of 857 patients admitted to the infectious disease service at St. Vincent's. I went through all of the cases and labeled them as people who inject drugs and the different substances that they've been using, and then used different open source large language models that could be used on a local computer, so we don't have any privacy issues. We're not sending patient important data to any third-party cloud service. I'll jump this slide, but of all of these models, the Llama-based model 3.3 did the best. Not as good as the models that Fabrice produced, because he's using these much more commercial, extensive versions of these models. And then here are the different cuts by different substances. Again, really poorly for prescription opioids and benzos. So sorry, I'm going a bit fast here, but I know we want to get to a bit of discussion. A few limitations. The big problem with NLP, right, is that you need notes. And for a lot of data sets, we're just never going to get notes. And then you need a lot of time for an annotator to actually go through these notes so you can evaluate how good it is. I wouldn't recommend you go throw AI to a problem without doing a really good evaluation. We definitely need to continue to do generalizability testing, see if it works in different settings. This work that I've been doing at St. Vincent's is single center. How does it look at multiple different centers across Sydney or across Australia? LLMs are really promising, but really computational intensive, and of course have privacy issues. We definitely need to use different de-identification pipelines, and these are much more challenging than they sound, but I think we have a solution. And then depending on your computer and the length of the node and the model you're using, the time to classification could be quite long, for anywhere from 4 to 29 seconds, which when you're doing 100 notes might not be much, but when you're doing 100,000, might be a lot of expensive computer time. So really the take-home messages is identifying people who inject drugs in electronic health records is really hard. Although NLP, I think, is getting extremely good. But I think for the next steps is really that combination approaches. So NLP with machine learning, with ICD codes, combining them all, I think will get us closer to that near perfection. So I just want to acknowledge the different people that have really mentored me and provided me support during my time at UCLA and now here at UNSW. So really thank you, and I leave my contact again, so if you want to reach out.
Wow, wonderful. Gosh, I learned so many things. I've got so many notes. Thanks so much. That was a great talk, David. So I'm going to start by inviting Amanda to please turn on her camera. I've got a bunch of questions, but before I jump in, I might give you the opportunity, Amanda, to reflect or ask a question before we head over to the Q&A. Welcome, Amanda.
Thanks, and thanks very much for inviting me to be a panelist today. So I guess amazing work, David. And as someone who's spent the best part of the last 20 years working with electronic health record data, I'm super excited about NLP and machine learning approaches. The work that you were highlighting from the Burnett group, I just wanted to pick up on. The interesting piece about their work was that for their final model, they got it to the point where there weren't any kind of those really key kind of identifiers at the top of the tree, like, you know, they'd been prescribed OIT, which was really interesting. So that the model was able to, I think with about 90% accuracy, predict someone had a history of injecting drug use without any without any of those direct or more sensible indicators. I guess that's interesting, and maybe as time goes on and the data changes, you need to keep refining that. We've actually got quite a bit of work going on in at Burnett in the NLP and the machine learning space, and there's also Ting Jia, who's part of Susie Nelson's group at the Monash Addiction Research Centre, is leading some work looking at emergency department data. So obviously there are lots of kind of applications coming up in Australia. One of the things I guess I wanted to reflect on is there's always this misnomer that you know, you can build these great models without any of the manual review. And again, I've spent a lot of my career doing the manual review. And I guess really, well, I'd be interested in hearing your reflection on, you know, how important that manual review is with any of this stuff. But also the context for, like, I think a lot of the work that's going to start happening in Australia is probably going to look quite different than the US, particularly because we don't have crack, for argument's sake. We don't have a lot of illicit fentanyls. It's largely pharmaceutical fentanyl. And I guess that some of those issues really kind of impact the route of administration. So most of our heroin, for argument's sake, is injected, while some of the fentanyl harms may not be among people who inject drugs. I'm not sure if you have any thoughts on any of that, and also about the idea of homelessness in the US as an indicator, which I'm not sure how well that would translate in our context, but I'd be interested in hearing your thoughts on some of that.
I'm not muted yet. No, well, thank you for contextualizing all this. And I mean, I was really impressed by that work from the Burnett. So really great work, and hopefully expanding into new areas and including NLP, I think would be really key. The biggest problem with a lot of this work is that then the models are really specific to that electronic health system. And I think that segues me into one of the comments you made around the importance of the annotation, or the importance about doing that manual piece. And I think if you have the time and resources to do the manual piece, that's just going to ensure that you can produce the best models or have the best results, because you can, some of the work that I presented that I'm doing at St. Vincent's is really taking the model off the shelf and seeing how it does. But I could make it better if I give it examples, say 10% of the data set, give it to show it which are which, and it'll probably improve on its predictions. And so that's something that in the work in the US with Fabrice, he was able to show, and hopefully it'll get published soon. And so, and the other part, the super importance about the annotation is I don't think it's fair to throw these AIs into the wild without having ongoing evaluation. Because look, labeling somebody as a person who injects drugs could have quite significant detriment to a person, right? There's stigma, there could be changes in their health services. Say I'm a person who's taking endone, I'm taking oxycodone for chronic pain, and this model says I'm an injector, and all of a sudden they cut me off of my endone. So it's going to be quite problematic, and then I might become an injector. No, that's kind of what happened a lot in the States. So I think it's really fundamental that we have this ongoing evaluation and ongoing annotation, but that's where all the work is. It takes so much time in doing all of that, and it's quite painful and boring, but it needs to be done. And then I guess the other piece around, I mean, I think Australia is really exciting. One, at least here in New South Wales, I think Jennifer's mentioning it, that we're going to have EPIC, at least statewide. I don't know what's happening in the other states, but that's going to be really exciting. If we have a unified electronic health records, and whoever's running this has availability for people to access the data and evaluate how we can implement these things, that would be incredible, and I think a game changer, which many, like in the States, other than the VA, you don't have really a cross-jurisdiction health network. Yeah, and then lastly, I mean, I think regarding our drug use profile in Australia versus the US with the availability of fentanyls and not, I've been particularly concerned in the injection drug use piece because that is an infectious diseases specialist. That's the route to get HIV, hepatitis C, endocarditis, and whatnot. Whereas, well, smoking, I think, is a little bit of harm reduction for my purposes, although I don't, even though people think, I don't think it necessarily is that much of an overdose risk reducer. But that's probably for another conversation. But I think that just needs to be part of the ongoing evaluation of those route of exposures, and our doctors documenting how people are using it, and we should be capturing and testing if the models are good at capturing these other distinct routes. I tried it in the St. Vincent's data, snorting, smoking, but it was just so few that those other routes were mentioned. I mean, most of the patients who inject drugs were either, as you mentioned, heroin or methamphetamine use. And there was a few methamphetamine use that was exclusively smoking, but it was also an infectious disease service, so most of them are injecting, and that's why they land in the infectious disease service.
And sorry, can I just make a comment on that? And sadly, you didn't show that data slide, but I think you mentioned it before, that stigma is likely to be the big thing, because a lot of these communities have not so great experiences within the hospital environment. So they may be reluctant to, say that they've got a background in injecting drug use, because there was underestimates in some of that stuff, which I know you would know.
Yeah, I mean, that's the biggest thing, right? There's a stigma from the patient. The patient is going to be reluctant to say it, right? And so there's going to be a bias there. The other bias is if the doctor actually records it in their note. Because there's also, look, once you label somebody as a person who injects drugs, that gets labeled for their perpetuity within the health system. And so some doctors don't even write it, that for whatever reasons that they don't document that thoroughly. So there are a lot of biases still with natural language processing. So that's why I still think the kind of bigger one is the pieces of doing combination, ICD codes, machine learning, NLP, all the data that we have access to.
Oh, it's so interesting. We've got a couple of questions, but I just wanted to pick up on one of those ideas from both of you about I'm a total intro person to all of this kind of modeling, but it made me wonder, like, is there a line? Like, what's the line for being acceptable to be used? We've talked about some of the data sets that you've looked at, and I think you mentioned, was it Fabrice, your student looked at, some of them were as high as 90%, and then some of the modeling that your team's been doing, Amanda, up close to 100%. Like, does it need to be 100%, or is this like a discussion that's happening? And where does that line lie?
I mean, I think it depends on your use case. I don't think that anybody has a set standard of how good is good enough. I think it depends on, is this going to be for clinical care? Is this going to be for surveillance purposes? How exact do you need to be? We're not flying to the moon, right? For many of this, but if it's somebody's patient like care, we do have to look at it as we're flying to the moon, and we want to get it right every time. The reality is that for much of the AI work, I think a general thought of a 5% error rate is the bar, because that's usually what is close to a human error rate.
Right. Okay. Interesting. Okay. Thanks. Okay, I've just looked at the clock. We've only got a couple of minutes. I'm going to try and speed through a couple of questions here. Sonia's wondering if there's a chance of accessing some of your slides, and I wonder if she could just reach out to you. You've provided your email address or
yeah, should be an email, and that would be the easiest way. I think it's going to get uploaded to YouTube. You can see them, but if you want to flip through them, just shoot me an email.
Thanks, great. Michaela's asking, so she said, thanks so much, that was really fascinating. Thinking about your findings from the American data set and the gap between the ICD codes and the model's performance, what do you think is going on there? Is there any way to reconcile those differences?
I think in America, I just want to say I did not mention one thing, that in the St. Vincent's data, only 2 cases out of the 149 had a code for opiate use disorder. And so we're not necessarily better coders in Australia, at least at St. Vincent's, in this one service that I was looking at. But I think a lot of the problems are that, at least in the States, not everybody who's an opiate use disorder is an injector, right? Or is a current injector. So they might have injected in the 60s, got hepatitis C, and then, I don't know, got a label of opiate use disorder that's in perpetuity within their health record. And then so the ICD algorithm picks these things up. And the other part with the ICD codes is we got to remember that they're billing codes in many places. They're not really research codes. And look, I used to put them in myself, and I was the worst. That, like, I had to put in 4 codes to get maximal billing, and hypertension, hyperlipidemia, diabetes, skin and soft tissue infection, I'm done. They could have 8 more, I don't care, because I've already bet the max. So there's a lot of biases, I think, ultimately with these codes.
Yeah, that's great. Yeah, it's yeah, always important to remember the purpose of what it was originally collected for, isn't it? Okay, we're short on time. I'm going to squeeze in one more question though, if I can. So Brendan has asked, so with big leaps between new NLP versions, how do you reconcile reproducibility over time? So he's saying, for example, analyzing data this year and then repeating it next year.
I think what would be great in this space for us to have a benchmarking data set. So a really well-coded data set that we could retest new models. New models come out every couple of months, or I mean, every day new models are posted on Hugging Face or on Autónoma, and they just come out too fast. But there are, once there is like a fundamental change, that improvement is much larger, I think we need to retest them. But the ideal place would be for us to have this benchmarking data set. We've produced one and put it online on our GitHub that based on Mimic, and it's if you email me, I can definitely point you to it. But I think that's all US based. I think having something in Australia would be wonderful.
Excellent, thank you. Look, we are out of time. I'm sorry, we're out of time, but we've got some questions here that we haven't managed to get to. And so I think David has said, please contact me if you want to continue the conversation. So I'd encourage you to please get in touch and see if there's more discussion to be had. Clearly, it's an area that people are really interested in, as am I. It's really fascinating to see how this works, in practice, and hearing your clinical perspectives from both of you on it as well. Congratulations, it's really interesting work. So thank you both to our panelists and to our speaker today. It's been a really interesting webinar. Next week, we are actually taking a break. Next week is NAIDOC week. And so I imagine a lot of people will be attending their local community events within their own communities. And we'll be back on the 17th, and we'll be looking at engaging with OAT in New South Wales and mixed method exploration of treatment access. So we'll look forward to seeing you on the 17th. Have a nice afternoon. Thank you.